We've delivered over 200,000 hours of training, and the biggest survival gap isn't the gunfight, it's medical care. So what needs to be in your medical training? That's today's topic. Jill, let's start off with you. Yeah. What's the problem with the way that we're doing medical training now?
Now medical training is focused, especially in this active shooter incident, this situation, is just time. We focused on the clock, rightfully, because time is blood loss. But not every person that is shot is going to need that surgical suite. Now, we hone in on that a lot in training, and you should hone in a lot on training. But I think where we're missing the boat is not appropriately triaging or follow-on triaging as far as loading the patients and getting them to the appropriate facility. If it's just one patient, load and go may be the way to go. But when we have multiple patients, if you have 7 red tag patients in front of you, how are we training our folks to appropriately identify which red tag is going to need the surgery? That's who needs to go first.
I like it.
Yeah, and Ron, back in the day, you were a paramedic before you spent a career in law enforcement, which puts you in an interesting position as a cop that would know a lot more about how to assess and triage and which patients needed to go first. What's the state of that level of training for law enforcement officers out there on the road today?
For law enforcement officers, it's very limited. There's very limited medical training. They may be trained to stop the bleed or tourniquet application, stuff like that, but that's about it. They don't understand. We talk about tactical triage and say, if you hear my voice move up against the wall, everyone else is red, which is a good start. But we don't utilize that with all cops. We don't teach that to all cops. We don't teach them why we do that. And I think that's, I don't expect cops to have the same capacity as a paramedic, but I do expect them they've got a duty to provide care to their highest level of training. And maybe we need to step up that level of training a little bit.
And it's funny, Ron, that you say that, because one of the questions that I ask officers when we're teaching a class, when we're having a one-on-one discussion, I'll ask, there's several pointed questions, and one of them is, how many tourniquets have you ever applied? And the shocking number is 0. The vast majority are 0. I'm from Jacksonville, and I know we apply a lot of them, and our SWAT team applies a lot of them on people. But the number of officers around the nation that don't, that even outside of training, they've been shown it, they've never put it on. I'm sure you've seen it too. Yeah. And it's something we need to look into.
You're saying they demonstrated in training, but they never actually practiced putting it on?
That is correct.
That's frightening. That's frightening.
Mm-hmm.
I think the place where this fundamentally breaks down in the active shooter environment is, if everything goes well, you've got your casualty collection point, and half dozen that are injured. So you apply START or SALT or whatever triage system you're using du jour. Great. You've got 7 reds laying in front of you. Not all of those are necessarily destined for a surgeon just because they're red. And which ones need to go first? And it feels to me like part of what has been lost over the years is that application of medical judgment in triage. And we're missing the opportunity. We focused and harped on time, and that was important, and it improved time. It decreased the time it was taking to transport everyone. But the thing that I think we got lost in the shuffle is we're not really looking at the medical assessment of those patients until they're back in the back of an ambulance. Right. And by then we've missed the boat. I think that's one of the things. So Jill, let's start off with, what are the key things that agency leadership should be looking for when they're selecting their mass casualty and warm zone care training for not only the medics and EMTs, but also for their law enforcement officers?
Yeah, I think that the training needs to be focused on the patient itself and injuries from a medical standpoint, not just this person was shot. Okay, we're going to take this person to the hospital. Where was the person shot? Let's find training that's going to dive into that medical component, the physiology of a penetrating wound. And what does that mean for triage? Whether you're using the, START, we find across the nation, or SALT is, a lot of agencies have been using that. Whatever method that is used by those fire and EMS personnel, the training needs to take into account a follow-on triage, a component of triage that allows you to make medical judgments. Use your training to tell, how are we going to distribute these patients? Is there someone that's going to be in that room that's going to take a lead and maybe, and loading appropriately by injuries? How are we going to get this patient before that patient? How are we going to make sure that patient number 1 that has a red tag has priority over patient number 2 that may also be a red tag? And how we find that is through medical judgment. And so the training has got to be one that will allow that will allow those fire and EMS personnel to utilize their training.
Billy, for the law enforcement officers that are in the room in the casualty collection point, and those that might be involved in helping move casualties to an ambulance exchange point, getting them loaded, those kinds of things, how important is it for those officers to be aware of the importance of picking the right individuals to go first, that the order matters?
It's literally life dependent.
Yeah.
Like literally, and when Jill was talking, I was thinking, just like we had referenced teaching the rescue personnel how to behave in a rescue task force, they need to teach us how to look at that, because I know for eons in the law enforcement community, we set up a perimeter and we didn't render A. We didn't do that. And now there's been a paradigm shift in that, and we do that. And I think just teaching them to know what to look for, like you're talking about, or even because there's going to be members of the RTF when they're doing triage that are basically standing around, for lack of a better term, and they need to be able to look at something, because I've seen somebody that like had a stab wound, that the wound was closed by adipose tissue and you couldn't tell, but it was a decompensating issue, and they need to be able to say, hey, I think this one's more problematic than we thought. Does that make sense?
Absolutely. Ron, do you think that there's a reasonable path forward to training basic law enforcement officers? You said, I don't expect them to perform as a level of a paramedic, but is there a missing opportunity here that the training gap needs to fill for officers on how to recognize the ones that probably need to prioritize? Like if they've been shot in the chest, might be a little more important than somebody shot in the leg.
I think that's critical. Also, I look at how many people have perished because they had survivable injuries, but no one took any action to get them to a place where they could get further medical care. Again, that's a training issue that leaves us all, I wouldn't say vulnerable, but leaves us all in a bad position. So we could do a better job at getting them to advanced care and getting them off the scene. We failed.
Yeah, Ron is so right, Bill. Those reading the after-action reports and a lot of the post-mortem reports from previous incidents, which is where your training should focus on continual improvement, especially on the medical side. It is humbling and frankly sad how we've missed the ball on just taking that training to that next level of, zero in on these injuries. It's not just a quick tag them red, throw them in the magic bus, and they'll be fine.
Right.
Ooh, as long as we get them in that ambulance, check, we're high-fiving. That's not the answer. The answer is to dive down into that medical training. That's why we are there with you.
Agreed.
Billy, what's that saying in the SWAT community? It's something like slow is smooth and
slow is smooth, smooth is fast. But you know what else is fast? Fast is fast. and we can't do it wrong enough, fast enough to make it right enough.
I like it.
So say that again.
You can't do it wrong enough, fast enough to make it right enough. So I think we need to do good assessments. I'm not saying a secondary survey necessarily on everybody, but I mean, we do need to do really good assessments on them initially.
Yeah,
And not to interrupt you, but I mean, one of the things, I'm not a proponent of tombstone courage, but so many of the delays are implemented because of fear of moving forward or wanting to clear and are saying known bleeding doesn't stop for unknown threats. And I think we've got to be able to move forward and do that and treat it as it is, not being afraid that the Romulans are going to land.
I think the other thing we have to deal with is a mindset. I'm reminded of a conversation, I've talked about this before on the podcast, that I had with a law enforcement officer who said, I just want him off my scene. Just get him in the damn ambulance and get him off my scene. And my reaction was like, no, what you want is for them to survive.
Right.
And in order for them to survive, I need to pick, of the 7 reds that are in the casualty collection point, I need to pick the ones that need to go right now. They're the right now
that
problems.
That
are viable.
Right.
Yeah. And that has to be grounded in some local knowledge of the local EMS system. What kind of ambulances do we have? Do we have the ones that still have bench seats where we can put 2 stretcher patients, one on the stretcher, one on a backboard on the bench? Or do we have captain's chairs now, in which case we're only transporting 1 stretcher patient? Can I put a green patient in the front seat of the ambulance or on the observer seat in the ambulance, or is that not prohibited? And does that rule go away if it's a mass casualty? Am I running BLS ambulances, ALS ambulances, or a combination? How do I know which is which? Those are local issues. Right. And so your training program that you adopt has to have a component that allows you to adapt how that action's going to occur for the local conditions, which is one of the reasons we advocated for the new loadmaster position in the casualty collection point. Yeah. One person whose job it is to say, this one, and this one. They go in an ambulance together. They're in the next ambulance. Put them by the door, and then when Bruiser and Johnny walk in, what do you need? Take those to the ambulance and get them loaded.
Right.
We're sequencing how we're loading them up and how we're transporting them, and we miss that right now.
We absolutely do, and unfortunately, it's more than that. It's not even that the 7 reds are the first ones to go out to the ambulance exchange point. All too often, it's a mixture.
Right.
And then
it's going to be the closest one to the door, Bill. Let's be honest. That's what's been happening. And that's what training should fix. So you need your training to fix that. It isn't just the clock. It is the appropriate medical interventions based on the clock. So, and I think that when you were just talking about the load master in a room, that's exactly what needs to happen. There's always somebody on a scene, right? If you don't know who it is, it's probably you. Somebody has to take charge of that casualty collection point, the area where the casualties are, and make clear decisions and vocalize those decisions. These 3 are going in the first ambulance if appropriate, or this one, because you've got to have those answers, those questions answered of the local capabilities. And those questions have many follow-on questions to them. Do you have the human resources? If you got 2 bench seats, but our medics, we were riding one, what can this person, this resource handle? Those questions have to be answered before the incident. So that's where the training.
Agreed. And use everybody to the maximum efficiency. And again, I keep referring to the officers that are assigned to the RTF. Use them as force multipliers in the sense of they should be able to do a pressure bandage, and the time to do it is not that day. They need to know, because again, if we've talked to them and they have never put a tourniquet on, then I promise you they've never done Curlex or a pressure bandage, right?
Right.
And I think you need to know how to do that before, because experience is something you learned that you needed to know 10 minutes ago. And that's true in this.
Yeah, I think that's a very good point. You have officers assigned to the rescue task force whose job it is to keep the task force safe, to be their security and move them through areas to where they need to be. But once you're operating in an area such as a casualty collection point or in a warm zone, there may be a contact team that's got that security posted. Right. And right now, you don't need to pull security.
Right.
You may be needed 5 minutes from now to pull security when 100%. We're moving. But right now, hey, can you hold this? Can we do this?
Absolutely.
Can we move that on and pass that around? I would also add, and I mentioned this when we talked about tactics, and I think it applies here as well. when we're talking about medicine, whether it's for cops, for EMTs, for paramedics, or everybody together, you got to keep the context true. So if you're going to do rescue task force movements, make sure that you're doing it with the radio communications that need to be done, the communications with tactical and triage occurring at the same time, and understanding that the security element is responsible for how they're going to navigate you there and where they're going to move you and how they're going to move you. And then the medical element is responsible for that medical mission.
Right.
And keeping all of that in context. With a casualty collection point, same thing. If you're going to operate in a casualty collection point, don't start with one already set up. Talk about how it gets set up and make everyone work through those communications. So again, as you split these up into small pieces, don't lose the context with the small pieces. Make sure that the little things all get done in that small drill.
Right.
Bill, earlier in a podcast earlier, we talked about beginning our training with the end in mind. And you just hit the nail on the head with that component. By establishing that casualty collection point, knowing what the ultimate goal is, why we're setting and why it needs to be established in a certain way, having law enforcement know that this isn't more appropriate position for an ambulance exchange point than that, because this is what ambulances have to do. This is what, how they maneuver. This locally is why we can only put one patient in this rig. That rig, we can load 2 or 3. Knowing those, having that local knowledge, begin your training with that ultimate goal and that end in mind is going to lead us to success.
Ron, I'm going to start with you and go around everybody for a quick wrap up here. Perfect wishes. What would you like to see in terms of mass casualty care, medical care for law enforcement and for fire EMS?
I think we need to broaden the training. I think that we focus so much on, law enforcement can teach the RTF how to move with an RTF. Well, I think medical needs to teach the law enforcement component there. If they need to help, this is what we expect you to do. Same with, we talk about a casualty collection point. It's usually constructed by the tactical teams that are downrange, but do they know why we create the casualty collection point, what it's used for, where it should be? We kind of skip over those things. We just assume that everyone understands that's what should happen. I think we just need to broaden our training so that we understand both sides of it. We don't have to do both sides, but we have to understand what you need to be successful. Right. And you need to understand what we need to be successful.
Jill, mass casualty care, what's your gotta have it list?
This is my gotta have it list is that clock, is that having those of us in the fire EMS side understand that the clock is vitally important to us, that bleeding begins the minute that a person has a penetrating wound. But that clock is specific to each patient. And how we determine that the clock's needs for this patient is a thorough medical evaluation using a rapid triage method that looks at the injury. To your point earlier, a lower leg wound, very different clock than a neck to navel wound. They have a different clock. While the clock is important, let's take our training to that next level where we're focused more on the physiology of the wounds.
Billy, what's on your gotta have it list for law enforcement, fire EMS in terms of medical care?
I think that law enforcement officers need to have actually done it a couple of times at minimum. I think if you're on a scene, are y'all going to stop him from putting a pressure bandage on? No. And do it. And I think we let golden opportunities by. I've preached forever about we let firefighters breach on a check welfare. Why? Get an opportunity to do a breaching run because the worst firefighter in the house can out-breach the best SWAT breacher. Yeah, is that not
absolutely?
Those are just hard truths. And I think we need to learn how to apply tourniquets. Yeah. We need to learn how to put a pressure bandage on. We need to know how to do curlex. And I think that's the do-all, end-all. Because, again, we all got into this. We wanted to get in shootings and car chases and stuff. We want to save lives. And that's part of it. And I think we got to be force multipliers on those RTFs. And when we're not even with an RTF, when we find ourselves there, we can help do things when everything is slowed down.
I think Jill said it best when she said, the clock is so important, but you've got to remember that it's a clock for each patient. And the clock is specific to the patient and specific to the nature of the injury. And I think my must-have list would be everyone, fire, EMS, law enforcement, everyone needs to understand that not everybody has to be rushed out. The injuries that require the rushing need to be rushed out. But if I'm sitting there looking at somebody that is having difficulty breathing because they've got a tension pneumo, that patient doesn't need to be rushed out. That patient needs
a needle,
a needle decompression so that they can start breathing
in a different
again.
Time zone. Yeah. They're a long time from midnight.
Yeah. They absolutely. So I think if we could get as a primer, the medical training could get everybody in the stack on the same page that, yes, the clock is the almighty clock, but that clock is unique to each patient.
Perfect.
Based on their injury. I think we could make a lot of progress on improving this.
Brilliant.
All right.
Agreed.
Ladies and gentlemen, thank you very much for coming in. For those of you that are listening, we've got a couple more podcasts coming up on how to pick great training for your agency. So be sure to like and subscribe so that you don't miss out on that. Thank you to our producer, Carla Torres. And until next time, stay safe.